Assalamu alaikum. Welcome to my channel Pharmacology Made Easy. Today we'll discuss about hypertension and antihypertensive medications. So at first, what is hypertension? Persistent rise of systolic blood pressure more or equal to 140 millimeter of mercury and diastolic blood pressure more or equal to 90 millimeter of mercury is known as hypertension. What are the etiology of hypertension? There are two important hypertension, as we know. One is essential or primary hypertension, and another one is secondary hypertension. In essential or primary hypertension, the 95% cause is unknown, and 95% cause is unknown in primary or essential hypertension, and previously it is called primary hypertension. Now it is called essential hypertension, but some risk factors are always present in essential hypertension. One is genetic factor. The Afro-American people and the Chinese people may develop hypertension. Increasing age and male patient may develop essential hypertension, and some environmental and social factors are responsible of causing essential hypertension, and that is increased salt intake, high alcohol intake, highly consumption of fatty food, highly consumption of saturated fatty acid in food, highly takes of animal protein, less intakes of vegetables and fresh fruits, and also physical inactivity, obesity are the important risk factor for causing essential hypertension. In secondary hypertension, the 5% cause we can known in hypertension, and 5% causes may have the some etiology that is responsible for secondary hypertension, and the cause is known to us in 5% cases is called secondary hypertension. The important causes of secondary hypertension: one is alcohol, the second one is obesity, the third one is preeclampsia. Then some kidney cause may responsible for causing secondary hypertension, that is adult polycystic kidney disease, the renal artery stenosis, uh, the acute glomerulonephritis, and some renal parenchymal disease may also cause hypertension. The some heart causes can cause hypertension, that is aortic aneurysm, myocarditis, rheumatic fever, uh, and coarctation of aorta. Coarctation of aorta is highly responsible for causing hypertension. Then some endocrine cause may lead hypertension. One is pheochromocytoma, hyperthyroidism, hypothyroidism, primary hyperaldosteronism, Liddle syndrome, congenital adrenal hyperplasia may cause hypertension. Some drugs may also contribute or may cause hypertension, that is anabolic steroid, oral contraceptive pill, uh, and also synthetic estrogen and carbendazole, and some sympathomimetic and catecholamines may cause hypertension. These are the important causes of secondary hypertension. Uh, if we grading the hypertension, in case of medicine, if we grade the hypertension are classified in grade 1, grade 2, and grade 3 hypertension. Grade 1 is called mild hypertension, grade 2 is called moderate hypertension, and grade 3 is called severe hypertension. In moderate hypertension, the systolic blood pressure range is 140 to 59, and the diastolic blood pressure range is 90 to 99, and it is called moderate hypertension. Sorry, it is called mild hypertension or grade 1 hypertension. In case of grade 2, the systolic blood pressure range is 160 to 179, and the diastolic blood pressure range is 100 to 109. And the severe hypertension or grade 3 hypertension, the systolic blood pressure range is more or equal to 180, and the diastolic blood pressure is more than 110 millimeter of mercury. This is in medicine, this is called the primary, this is called the mild hypertension, this is called moderate, and this is called the severe hypertension. These are the one classification of hypertension. Another, in pharmacology, we said the hypertension when the blood pressure is more or equal to systolic blood pressure 140 and more or equal to diastolic blood pressure more than 90, it is called hypertension, and one is stage 1 hypertension, and another one is stage 2 hypertension. In case of stage 1 hypertension, the systolic blood pressure range is 140 to 159, and in diastolic blood pressure range is 90 to 99. And in case of stage 2 hypertension in pharmacology, the systolic blood pressure range is more or equal to 160, and the diastolic blood pressure is more or equal to 100 millimeter of mercury. So these are the we can categorize the hypertension according to the blood pressure. Now, what are the clinical features in hypertension? Always there is a asymptomatic in nature, and when we took the blood pressure, we see that it may be rise in normal range. So repeated measurement of blood pressure, that is home blood pressure monitoring and ambulatory blood pressure monitoring, we can diagnose the patient of hypertension. And also some important secondary cause that shows some sign to us that is related in hypertension. One is a radiofemoral delay that is present in coarctation of aorta. One is renal bruit you can found in case of renal artery stenosis. In case of AGN, there will be hypertension, there will be generalized edema, there will be scanty type of urine, and if we investigate in acute glomerulonephritis, there will be RBC in the urine test. And also in case of pheochromocytoma, the pheochromocytoma triad is present over there. One is headache, one is palpitation, and another one is sweating or perspiration. This triad also present over the pheochromocytoma, and you can diagnose the pheochromocytoma by measuring the urinary metanephrine or vinyl mandelic acid. The level of vinyl mandelic acid will be very high in case of pheochromocytoma, and the most significant specified diagnosis for pheochromocytoma is uh, MRI of lower abdomen, where you can see the tumors present over the adrenal gland, and or CT scan can be done over there. In case of Cushing syndrome, we know that dexamethasone suppression test can be diagnosed the Cushing syndrome, and the sign of Cushing syndrome, we as all know the buffalo hump, pendulous abdomen, the abdominal striae, that is Cushing's over the skin, and also some increased rise of blood pressure, increased hyperglycemia, or increased blood sugar level, and also there is presence of bruise, there is a delayed wound healing, there is a infection repeatedly. That we can diagnose a Cushing syndrome. In case of primary hyperaldosteronism, we know everyone that if we see the serum electrolytes, the sodium level will be high, the potassium level will be low, and some drugs may cause the hypertension. And by knowing the drug history and also knowing the family history, family history, we can evaluate the hypertension signs in this patient. So what are the important investigation we can do in hypertension? We can do some of the investigation that is so much necessary to diagnose the secondary cause of hypertension, because the primary cause is unknown to us. If we go unknown to us, and it is the etiology is unknown to us, and the routine investigation we can do for primary investigation in hypertension, that is complete blood count, one ECG, one lipid profile, and sometimes serum creatinine may be necessary to diagnose the disease. But in case of a specific disease, we have to go for some special investigation. To know the atherosclerosis, we have to go for the serum lipid profile, and where we can see there is a distortion over the serum cholesterol and HDL level. And in serum cholesterol and HDL ratio, as we know, if it is high, then there will be hyperlipidemia and there is a chance of atherosclerosis. In case of renal artery stenosis, we can go for renal angiography. In case of APKD, adult polycystic kidney disease, we can go for ultrasonography of the lower abdomen to see the cyst over the kidney. And also for the pheochromocytoma, we can go for the urinary vinyl mandelic acid test to see the levels of vinyl mandelic acid, and we can go for the CT scan and MRI over the adrenal gland. And sometimes we go for the echo and ECG. In ECG, we can see the myocarditis, we can see the rheumatic fever change in ECG. And there is also some echo for see the complications of hypertension, if there is left ventricular hypertrophy or if there is heart failure. What is the ejection fraction, we have to know over there. So these are the important investigations that you can do for hypertension. Sometimes serum creatinine gives us a clue for diagnosis hypertension, that is serum creatinine may be high in case of CKD, in case of renal failure, or in case of primary hyperaldosteronism, and to look for the electrolyte levels. Sometimes we go for the further investigation to see the primary hyperaldosteronism, and in case of primary hyperaldosteronism, the electrolytes, the sodium will be high, the serum sodium level will be high, the potassium level will be less. So these are the important investigation we can do for hypertension. Now the approach of management of hypertension, and one is non-pharmacological approach and another one is pharmacological approach. Non-pharmacological approach, uh, we have to restrict, or we have to avoid the smoking, we have to avoid the fatty food, we have to avoid the alcohol, we have to intake vegetables, we have to avoid the saturated fatty acid, we have to go for the physical exercise, and we should have a lifestyle modification is an important in case of a non-pharmacological approach to relief of hypertension. In case of mild hypertension, we can go for the lifestyle modification and see what will be the conditions of blood pressure after 7 to 10 days. Then we can see the blood pressure sometimes becomes less, and there is and it will be normal, and so there is nothing medication over there after lifestyle modification in case of mild hypertension. But in case of moderate and severe hypertension, uh, we have to maintain the lifestyle modification and also give antihypertensive medications. So now the pharmacological approach, we have a lot of drug to uh, to control our blood pressure, uh, and the treatment modalities are more or less same in every discipline. And the treatment modalities, as we know, age is less than 55 years and age is more than 55 years. Age is less than 55 years and age is more than 55 years, the two category we are classified. In case of age more than 55 years, the Afro-American people, the black people with some comorbidities, we have to go for some drugs. And in case of age less than 55 years, we go for some another drug. Okay, age less than 55 years, in stage 1 hypertension, we give only A drugs. A means AC inhibitors or ARB. Or in case of age more than 55 years, the Afro-American people, the Caribbean people, the family history which have hypertensive, which have a hypertension history, and also the black people and the comorbidities people, we choose the C drug. The C means calcium channel blocker. If these patient by using antihypertensive drug the blood pressure can't control, then in stage 2 we go for, in two category patient we give A plus C drug, means we give ARB or calcium channel blocker, we give AC inhibitors plus calcium channel blocker. If this patient cannot control the blood pressure by this drug, we go for A plus C plus D drug. That means we give ACE inhibitors or ARB plus calcium channel blocker plus D for diuretics. And in case of stage 4, if we not control hypertension by these three drugs, then we go for A plus C plus D with adding alpha blocker or another beta blocker or another diuretics uh, plus we have to go for searching the risk factor if there is any dangerous risk factor over present, or we have to go for reinvestigations for this patient. So this is the overall treatment modalities in hypertension. So what are the drugs we are giving in hypertension? From the head, by giving we have to give we can give many more drugs to treat the hypertension, but this is the treatment modalities of hypertension. Okay, what are the drugs we can choose in hypertension? We can choose centrally sympathopresic agent, that is guanafacin, guanafens, alpha-metal, dopa, clonidine, but these drugs are not used available and cannot use by their more side effects. These drugs are not used daily. We can give the another drug, that is adrenergic neuron blockers, that is reserpine, that is guanethidine, that is guanadrel. We can give this type of drug, but this drug also not given nowadays. We can give another drug, that is sympathetic ganglion blockers, or sympathetic which drug acts on the sympathetic ganglia, that is trimethoprim. This drug also not given in hypertension. Nowadays we can give the beta blockers. If we tell the names of the beta blockers, you all know the atenolol, propanolol, the acebutolol, the pindolol, the metoprolol, bisoprolol, betaxolol. These are the beta blockers we can give in hypertension. The alpha blockers we can give in hypertension, that is prazosin, tadalafil, doxazosin, phentonamine, phenoxybutynin. These are the alpha blockers that we give in hypertension. We can give ACE inhibitors in hypertension, that is perindopril, lisinopril, captopril, enalapril, fosinopril, benzapril. These are the important ACE inhibitors we can give in hypertension. We can give also angiotensin receptor blocker, that is losartan, valsartan, candesartan, irbesartan. These are the ARV. We also give the diuretics to control hypertension, the loop diuretics, the thiazide diuretics, the potassium sparing diuretics, sometimes the osmotic diuretics may also give in controlling the hypertension. So these are the also we give vasodilators. The direct vasodilators is calcium channel blockers, and calcium channel blockers are amlodipine, nifedipine, nimodipine, nicardipine, and also some vasodilators we can give in hypertension, that is hydrolazine, minoxidil, sodium nitroprusside, nitroglycerin. These are the important vasodilators that we give in controlling of hypertension. So these are the drugs that we can give to control hypertension. So today we will discuss about the beta blockers. At first, before starting the beta blockers, how it control our blood pressure, where we can use the beta blockers, we have to know some comorbidities, or we have to know some another types of hypertension that is so much necessary. One type of hypertension is called white coat hypertension. The white coat hypertension means the patient may get rise of blood pressure when they go to the clinic to meet a physician about his problem, or about his any type of disease. When they go to the clinics, when the clinician measured his or her blood pressure, the blood pressure may be rise, and this type of rise blood pressure is called white coat hypertension. And the treatment is supportive treatment and counseling, and also give some relaxation therapy may also help this patient to control his these types of hypertension. Another hypertension we called refractory hypertension, when two or more drugs cannot control the blood pressure, and this occurs in renal artery stenosis, and in case of pheochromocytoma, that is called the refractory hypertension. This refractory hypertension sometimes may be called resistant hypertension, when more than two drugs or three drugs cannot control the hypertension or cannot control our normal rise of blood pressure, that is called resistant hypertension. In case of resistant hypertension, we have to give supportive treatment, and we can add spironolactone over there to control this hypertension. If this hypertension cannot be controlled, so don't worry, only give supportive treatment, but the drug should be continued for this patient. This is the treatment modalities for refractory or resistant hypertension. And another important hypertension in our medical science, that is we have to know so necessary that is so necessary that we have to know it, and we have to also memorize it, that is hypertensive emergency. Sometimes it is called malignant hypertension or accelerated hypertension. Malignant hypertension or accelerated hypertension may be said hypertensive urgency also. Sometimes we say also sometimes we can call it hypertensive crisis. So the definition of malignant hypertension or accelerated hypertension, when the systolic blood pressure is more than 200 and the diastolic blood pressure is more than 120, with the damage of any organ or damage of any end organ, is called or is known as malignant hypertension. It is characterized by microvascular narrowing due to microvascular inflammation over there, and that causes the microvascular narrowing, which leads to fibrinoid necrosis over there, and there is a intravascular coagulation. And that's why sometimes it is the main pathology of developing malignant hypertension. The important sign of malignant hypertension is papilloedema. There will be retinal vessel rupture over the retina, and you can see it by fundoscopy. In hypertensive retinopathy, there will be grade 3 or grade 4 type of hypertensive retinopathy you can found on fundoscopy, and we can see the hard exudate or cottonwool exudate with hemorrhage over there. Okay. What are the condition may arise in malignant hypertension? There will be hypertensive retinopathy, there will be kidney failure, there will be left ventricular hypertrophy, there will be heart failure may develop, there may be stroke in case of malignant hypertension. The treatment of malignant hypertension is so simple, but we have to memorize, or we have to realize this situation. We do not reducing blood sugar too early in this type of patient. If you reducing blood sugar if you reducing the blood pressure too early by using antihypertensive drug or any vasodilating drug to reduce the blood pressure so early, there will be cerebral hypoperfusion, there will be cerebral tissue hypoperfusion that altered the autoregulation of blood pressure, and which causes stroke in this type of patient again. If this is a patient in stroke for malignant hypertension, if you reduce his or her blood pressure too early by vasodilating drug, the stroke will be occurs again. So do not reduce the blood pressure too early. Second is reduce 25% blood pressure reduction, not over a day, and keep the blood pressure 150 to 100 millimeter of mercury for next 7 days. Do not do not control it less than 150 or 100 millimeter of mercury. Reduce the blood pressure less less rapidly, and control the blood pressure slowly. So these are the we can so what will be the treatment plan, what will the we can give also some books tells we can give oral drugs, and it is best for this type of patient if the patient is able to take the drug, if the patient is fit, if the patient is swallowing, if the patient can talk, if the patient is GCS is good, then we can give oral drugs. The oral drugs are labetalol, nifedipine, uh, nifedipine, uh, carvedilol. These are the drugs we can choose in case of orally. If we give the patient intravenous drug, the intravenous drugs that control the malignant hypertension, one is hydralazine, another one is sodium nitroprusside, another one is glyceryl trinitrate. We can also give intravenous labetalol also. So these are the important drugs for controlling malignant hypertension. Okay, now we'll discuss today about beta blockers. After starting beta blockers, this video will be end, and the next video will talk about beta blockers. Thank you.